Welcome to January 2021 CME. This month we're going to talk about high-risk chief complaints and clinical decision-making. Objectives. We will define the importance of clinical decision-making, understand how patient assessment directly affects our clinical decision-making, review the common assessment process and diagnostic tools used to determine the differential diagnosis. Overall, we will improve the Pinellas County EMS clinicians' ability to identify and manage patients with chest pain or shortness of breath. Let's discuss critical decision-making. Before we look at patient assessment, let's discuss how we make decisions during and based on the information we gather from our assessment. First, the goals for assessment. When we are treating our patient, think about the goals of care. For instance, let's say you have a patient who needs pain relief. Refer to MOM's protocol M13 for pain management. The goals of care state that you are to provide reasonable, safe pain management. It does not specifically say total pain relief. Another example of this is when treating a patient providing fluid resuscitation. When we provide fluids, we are not necessarily rehydrating our patient, but we're supporting their vital signs. You should always be thinking ahead to identify any potential problems. Prior to either medicating or using any equipment on the patient, we should also consider any potential problems that may arise. For example, if you administer nitro, you should expect a drop in blood pressure. Or, if using SMR, we should expect the patient to complain that they are uncomfortable. Keep in mind, our treatment can create other problems. When performing any procedure, you could create another problem, so it's better to understand the pathophysiology, pharmacokinetics, and pharmacodynamics. This will help you to be prepared for any adverse side effects that may occur. We always need to do what is best for our patient. When performing procedures, don't just fill in the EPCR. We are not providing good care if we're just filling out the computer. The thoughtful clinician will determine what is best for their patient, what is necessary, and what is not. Be a good detective. This starts when you arrive on scene. Maintain good situational awareness in all situations, not just scene safety. When you arrive on scene of a call, you should be investigating your surroundings and be attentive to what is around you, how the patient presents, and identify medical devices, medications, and other clues. Clues inside the home can provide information as to what might be going on with your patient. We commonly use the phrase, "What do I see? What do I hear? And what do I smell?" Using our senses can help provide us with valuable clues. The secondary assessment includes the physical exam. This is when you're going to put your hands on the patient. You're going to gather intel using your sample history. You'll perform interviews and collect information from the patient, family, friends, and bystanders on scene. Think about this as being forensic evidence that provides you with clarity and supportive information when determining your differential diagnosis. It's important to touch your patients when performing the physical exam. This is a therapeutic interaction as well as the actual assessment. Patients appreciate you taking the time to both listen and examine them. If a patient has a very specific complaint, our exam may be focused on that area of concern, but make sure you are fully assessing your patients and touch your patients when they have a complaint. How do we differentiate our approach in patient care based on patient complaint? We use specific playbooks. In Pinellas County, we use the systematic approach to patient care. PHTLS for trauma patients, ACLS for cardiac problems, FAST ED for stroke symptoms, and HAND-TEVI for treating pediatric patients. Also, the pediatric assessment triangle when approaching pediatric patients. In the end, all the physiological approaches to assessment and care become our playbooks and our roles. The MOM's manual and the bundles of care are also applied. Are we all thinking the same thing? Let me describe for you what a shared mental model means. While assessing a patient, each clinician analyzes the information and forms differential diagnosis with that information, thus driving treatment. Using the same assessment pathway, clinicians should be in the same general area about what's going on with the patient. In other words, we are reading from the same sheet of music. But if we are assessing the patient and not completely listening to all of the information that's gathered and not listening to each other, we could end up in a different thought process and thinking something different is going on with our patient. Many times we do think differently for several reasons. Different experience levels or educational levels are just a few. The idea is to have a standard model for assessment. Here, we use a systematic approach to patient care. This is so we don't end up in two drastically different treatment pathways. So as you can see in the picture, each clinician hears the complaint of abdominal pain. After they complete their assessment, they should both be thinking similar differential diagnosis. But if we are not using the same assessment model, we could be going very different directions. Understanding the pathway, we will be able to prioritize the complaints and make certain that everyone is on the same page. It's important to notice patterns. Here are some common patterns that we've seen. Chest pain that radiates or causes skin changes are signs of MI. noting that chest pain is an indicator of ACS. Sometimes an MI might not have pain, but generalized weakness. Don't be afraid to double check yourself. It's better to double check yourself than miss something big. Let's talk about pitfalls. One assessment pitfall that we don't want to fall into is satisfaction of search. This means that we tend to think of something as less than it may be. For example, a patient with altered mental status. We may check vital signs, blood sugar, provide oxygen, IV, 12 lead, and then say, we've done everything we can, there's nothing else to assess, so let's just transport to the hospital. Make sure we think critically and continue to assess our patients. Ask questions to the patient or caregiver, discuss the findings and information with fellow clinicians, and work together to try to solve the problem. The assessment of a patient is an active process that we must be committed to refining. Assessment requires practice and requires conscious effort to not fall into mental traps or biases. Continuous assessment throughout the call will help you monitor condition changes in your patients. Make sure that you're always putting your hands on your patients and you're giving them a thorough head-to-toe assessment. Assessment should be continuous throughout your call and your time with the patient. Lastly, avoid complacency at all costs. Just because you know a patient and you run on them regularly does not mean you should get 2 sets of vitals that are 5 minutes apart and enter information in the EPCR. Fully assess every patient.